Hi, my name is Dr. Yvonne Parry. I am a senior lecturer at Flinders University. I would like to welcome you to this presentation on housing instability, homelessness, and children. The first thing I'd like to do is do an acknowledgement of country, and I'd like to acknowledge that the land that I work and live on is the traditional lands of the Kaurna people. I acknowledge their connections to country. I acknowledge their leaders, past, present, and emerging, and I respect and acknowledge that they are the spiritual custodians of the land and recognise their cultural and heritage beliefs. I would also like to welcome all First Nations peoples to this presentation and also acknowledge the losses incurred by First Nation people in sharing their land with us. So this presentation, we will actually cover a little bit of child development and why that is important in relation to housing instability and homelessness. I would also like to present the development and the need for particular developmental competencies that set them up for life. There is a saying that says that childhood impacts directly on our adulthood, or as an adult we are a reflection of the childhood we had, and I think that that's a really important thing to remember. We'll have a little bit of a look at housing instability and its impact on language development, socialisation, those sorts of things, and the trauma of housing instability on children, and really what children need in housing instability and homelessness. And the links to the services. And that's where some of the research I've been doing with my team comes in. I think to set this up, we need to think about this saying from Frederick Douglass, who said that it's much easier to build strong children than it is to repair broken adults. And I think that's an important thing when we're thinking about how homelessness and housing instability impacts on children, about providing those children with the best possible childhood they can have by linking them in with the services they need developmentally. If we have a look at this next slide, it is the ARACY CAARS assessment slide. And I think looking at this slide, we actually see that childhood is impacted by a lot of different aspects around us in our environment and that have direct contact with us. And that housing actually forms one of the parts of the inner circle for the child. And that is our sense of safety. Children develop a sense of safety by being in stable housing. They develop a good interaction with their family, with their peers. So they're socialised appropriately by being connected to family, connected through housing to family. Also, we need to have, as a child, good connections to physical health and to services that provide us with the health services we need. These things impact on our sense of well-being, our emotional well-being, and also impact on our mental health. So it's very important that we actually have these things in our childhood for us to develop as into adulthood and feel safe. We need a sense of belonging, a sense of connection to our identity, to our culture, to our cultural identity. And some of that comes from our place of being. If we are a child and have things around us that we know are ours and our place of being, it actually gives us a better sense of emotional well-being and health. And it also, of course, means that we have stronger relationships with the adults that are around us. And that, of course, impacts on our learning and our development. I also want to raise at this time the concept of sensitive and critical periods of development. Now, during our development, there are times when we are sensitive to particular things happening. So we are biologically programmed, if you like, to actually pick up on these particular things and these particular things happening. Now, with a sensitive period, it's actually a gradual development of things over a particularly drawn out period of time. And an example of that is our language, how we develop language. We develop language between 3 to 7 years of age. So we have a fairly long drawn out period of time where we can develop language very easily. When we move past those years, 7 years, we can still learn language. We can still pick up language and expand our language. It takes a lot more effort from us to do that after 7 years of age. So if you're in a house or a family where there's minimal language use, then sometimes as a teenager it's going to be harder for you to pick up and expand your vocabulary if you have not had that introduction to language at that sensitive period of your development. When we look at critical periods of development, it is an abrupt time when we are biologically primed, if you like, to actually pick up those types of development. So the work by Hubel and Wiesel focused on critical periods of development, and they did some experiments. So please, people out there, I have not done this. It's been done by other people and it was done a while ago. And what they did was they had kittens and they popped a blindfold on one eye of the kitten so the kitten could not see out of that eye, and then 3 months later they took the blindfold off. The cat did develop some vision in the eye that had been blindfolded, but even into adulthood, the vision in that eye was impaired. So that is a critical period of our development. So we are receptive at that time to particular things happening. Now, for us as human beings, those things like, eye development, for instance, happen really early on, and we'll have a look at a slide in a moment for that. So if we're suffering from or being exposed to housing instability or homelessness during that time, there may be critical things in our development that we're not actually being exposed to or not actually getting because of the trauma of being exposed to housing instability. So here we have a little bit more information on the sensitive periods versus critical periods of our development. So for us as human beings, language development, for instance, our visual capabilities, for instance, all of those things happen at different times, and some of them are sensitive things such as language development, and some of them are critical things such as visual development and visual capability. So for human beings, it happens between 8 months and 3 years. So we can see that the preschool years especially are very sensitive times for our brain to develop those neural pathways for us. Of course, it goes into adulthood as well, and there are things such as brain plasticity and other things that we can use to stimulate those areas of the brain that might not have received development at those critical periods. But that takes a lot of effort. It takes a lot of intensive interventions. We know from the research that's been done internationally and nationally that if we're looking at things, especially from a child-focused viewpoint or a child-aware viewpoint, that it is much easier to address issues in childhood, early intervention, early in the life of the child and early in the life of the problem. It is much easier for us to address these things early on, and it has a less of a cost to us as a public health intervention than if we wait. You know, we know that children who are exposed to disadvantage and homelessness and housing instability can have those things impact on their development and on their health throughout their life, gradually becoming more in some ways costly for them and for us if they're not addressed early on. So the impacts of family homelessness, and this is really my area of research. I've looked at family homelessness for at least 2 decades now, and have started and have a research team that looks at really the impact on children of family homelessness. We know from the work that's come out recently by Valentine et al. That 67% of homeless people are families, and they require a different response. This is not an either-or discussion. This is this response and it's inclusive of everyone who is homeless. So it's about responding to those people who are sleeping rough. It's about responding to those families who find themselves in housing instability and homelessness. We know that the homelessness services have great strengths and have been working for many, many decades in this sector, and really have the trust of the people who use those services as the main focus of what it is they're delivering. We know that homelessness is driven by structural factors and individual factors, and that those structural factors are beyond the control of the families and individuals who find themselves in the homelessness sector. We need to respond to both the individual and the structural factors if we are going to improve the outcomes for children, improve the outcomes for families, and improve the outcomes for those people who are sleeping rough. We also know that this new focus has impacted on the staff because they're having to deal with new strategic goals and new policies in the area of homelessness. So our research actually has looked at some of these things. So we know that children actually incur a great number of losses due to homelessness. If we think back to that ARACY slide right at the beginning of this presentation, we know that children's need for housing, homes, a sense of security impacts on their mental health and well-being. So children often incur great losses in through the process of housing instability and homelessness, that they have a sense of feeling scared, they have a sense of feeling unsafe, and there are a number of references at the end of this presentation on those sorts of things. They often feel a sense of anxiety and loss and worry about moving. They often desire, children like routine. It actually helps them in their development having a routine. They have a sense of a loss of personal space and privacy. What happens to children during housing instability is that often they lose their space. If we end up moving in with family, there's overcrowding. So the children then don't have their own space. They have to share space with other children or other adults. They lose their possessions. They might lose favourite things, favourite teddies or favourite things that they rely on to help them feel safe and secure. They will often lose family or friends or pets because of the family may have to go somewhere completely different. For a child's development then, this socialisation and all these losses impact on their connections and relationships with peers, with families, with friends, even their sense of developmental security, if you like, is lost. They have a decreased engagement with education, so the children often cannot go to preschool, kindergarten, school. They have a decreased connection with health, often relying on ad hoc emergency department services, which are not designed to look after children's long-term developmental needs. We know that 22% of all Australian children between the ages of 0 and 14 years live in housing instability, and that this will impact on their adulthood, on their adult outcomes. That periods of housing instability create trauma, and that this trauma is accumulative for children. We also know that 26% of all Australian children are Aboriginal, Indigenous, Torres Strait Islanders. The policy response to children in homelessness sort of commenced in around 2009, when the South Australian government actually decided that they would instill or enact the no wrong door policy directive. So no matter where a child presented, that child, there was going to be no wrong door. If they presented at emergency department and it was discovered that they were in homelessness, that they would be directed then into homelessness services. That if they presented to homelessness services and they needed some other service, such as a relationship service or therapy or whatever, that they would then be directed into that particular service. So that was the idea behind the no wrong door policy directive. Along with that became the requirement to implement a child-aware approach. So in a child-aware approach, the child is the centre of the intervention, and all of the services that the child needs is then enveloped around the child to support the family. So that really entailed improving responses to homeless children and their families, and that included the child's health and welfare requirements. So there was an acknowledgement that there was a need to improve services to children, that this could be gained by a child-aware approach or a child-centred approach, and that the children needed to be linked to other services. And that included things like Together for Kids, education, health and social interactions. This also impacted on the staff. So this first research project that we did in conjunction with Uniting Care Wesley Bowden in 2012 looked at the changes and how those had impacted on the staff. So we did interviews with parents and staff, and what we asked the parents was, how did the service respond to the children? What were the needs of the children and how did they respond? And what we asked the staff was, what was the impact of this change in policy and change in directives for you as a worker in dealing with this? And we did a thematic analysis on that. And so we looked at the staff's knowledge and their attitudes and their understanding of children. We also looked at the staff's knowledge of the children's needs and their developmental needs and growth needs. So we interviewed 7 staff and we interviewed 7 parents and looked at the current practice and behaviour and looked at the time needed now to look after staff, and that's children. That's what came out for the staff, was that there was more time needed to engage with the families and spend time looking at the children's needs, and that they actually didn't have the referral expertise. They didn't know where to refer some of the children on presenting with particular things. So we developed up an education package that I delivered to address the gaps around child-aware approaches and also child development. We also developed up a quick assessment tool that the staff could use in the homelessness service to quickly assess where the children were at. The impact on the frontline staff for this change that happened in 2009, 2010 was that they knew they didn't have the knowledge, and they also lacked confidence in dealing with children. They'd only focused on the parents before. That there was a conflict of interest because the case managers were assigned to work with the parents, but sometimes they became aware of things like child protection concerns, so they needed then to focus on the child. And so they sometimes had difficulty in seeing the child's primary needs. They had varying levels of qualification, and they sometimes found that these families were very complex families, very difficult families, and they needed to spend a lot more time in dealing with the children as well as the family needs. There were management responses to this, and the services changed. So as a direct result of that first research project, the management at Uniting Care Wesley employed a child-focused caseworker to actually help the caseworkers and have a children's loads, and actually became aware from this first project that there were no links to health, as it were, for the children and for the parents. Our second research project, so we used the knowledge and the information to then innovate, and our innovation was a nursing student placement. So we thought we could address some of the needs that were highlighted through a nursing student placement, and this was a two-pronged approach because we wanted the nurses to become aware of their myths and the realities around homelessness, in that the majority of people in homelessness are actually families. We wanted the nursing students to understand ways that they could actually assist when they became registered nurses and support the needs of homeless children and families. And so, you know, change discharge practices, for instance, from hospitals. We also needed the social workers to become aware that nursing students had specialist knowledge around health that maybe they didn't have, and that we were upskilling the staff as well as upskilling the nursing students. The Wesley Uniting Care Bowden developed an education package for the students who were going in there, which was just fantastic. And we've also had physiotherapy students go in there. We've also had disability students go in there as well. And we also developed up an assessment tool for the nursing students to use. So the outcomes from research project 2 was that the nursing students, and we've put in some quotes here for you to have a look at. So the nursing students, it really expanded their ideas around what was homelessness and who was homeless in our population, and how quickly someone could go being housed to being in housing instability. So the nursing students were actually also surprised on their knowledge of health. It also had an impact on that the nursing students took this learning away, and then when they became registered nurses, we had follow-ups with them, and then when they became registered nurses, that improved their practices when they were working in the acute care setting to actually be aware of the needs of homeless families. The other thing that I think was a learning for the social workers in the homelessness service was that they became aware that the nursing students actually had a lot of knowledge. For instance, they had a lot of knowledge around health. The clients trusted them a great deal and told them a lot about their health, which they hadn't done previously. So from that research project, we're now into research project number 3. And this is a research project that we're doing at the moment. And it's about keeping keeping the children, connected to health and education, and this was about providing a nurse practitioner. Now, nurse practitioners are a much higher level than registered nurses or practice nurses. They are autonomous practitioners who have at least 6 years of education in working with children and working with at a much higher level. So our pilot research, working in partnership with Uniting Care Wesley Bowden and the Inner Southern Homelessness Service, looked at the needs of the children. And to our knowledge, this is the first time that children's needs in homelessness have actually been assessed, received an in-depth assessment, and then referrals, and then a follow-up of that referral. So if we have a look at the current research and the research methods, there is an extensive paediatric mental and physical health assessment conducted by the nurse practitioner. Now, as you saw on the last slide, nurse practitioners can write prescriptions for antibiotics and those sorts of things. They can write direct referrals into mental health, into craniofacial, into other medical and other services that the children may need. So they're working at a much higher level and can provide a much more in-depth assessment and service for the children. So the data on that assessment, that initial assessment, is entered by the nurse practitioner, and it covers things such as the age of the child, the presenting conditions for the child, the severity of the conditions, the immunisation status of the child, whether the child identifies as Aboriginal or Torres Strait Islander or has a refugee identity, and also track the referral pathway. So this is quite an intensive intervention at a much higher level than has previously been provided for these children. So the health needs are determined by the nurse practitioner, the prescriptions are written, the referrals are written by the nurse practitioner, and then there's other data collection, such as their access to child, to transport. Will they get to the referral? The parental mental health issues. Does the parent have agoraphobia or anxiety? And will that impact then on the uptake of the referral? Because one of the things that happens, we know from the international research, is that children living in housing instability and homelessness often do not attend at a referral. We are then following up on the referral, so tracking that referral. We are then looking at this model of care, which we are calling it a nurse practitioner health navigator. So the nurse practitioner and the child are in the middle, and the nurse practitioner navigates all of those services that the child will need. Our next stage of the research, which we're looking for funding for, is at the interviews with the parents to actually see the impact of the nurse practitioner model of care, and have a look at the longitudinally for the time that the homelessness services with these families look at if there is an improvement in the child's health, and also looking at a satisfaction survey and determining the levels of the child's health improvement. So here is the child's journey through the nurse practitioner health navigator model of care. So they come into Inner Southern Homelessness Service. The staff alert the nurse practitioner to the family on intake, and that we actually collect the data on where the child's health is at. We do a comprehensive assessment, a health checkup, and then do a referral and then follow up on those particular families. What our research to this point has found is that only 11% of the children that are attending the homelessness service are appropriately and fully immunised, that children have missed immunisations, that the immunisations have occurred in an ad hoc fashion, so they are not up to date, which actually places the children at risk of some of these conditions, highly contagious conditions. We've also noticed that 24% of the children attending have a developmental delay, including for some of them craniosynostosis, which is the melding of the plates of our heads too soon. So if that happens too soon in the child's development, then the brain can't grow and the brain can't expand because our head is stuck at that size. And so the children end up with a developmental delay. Now that needs a surgical intervention. It needs a timely surgical intervention. So it's quite, when we think back to the development and our significant periods and our critical periods, this needs to be done to enable the child's brain to grow and develop. There's plagiocephaly, there's severe motor delay, there's developmental delay. 66% of the children attending at Inner Southern Homelessness in the nurse practitioner-led clinic needed an immediate intervention. Of these, 44% were assessed as having severe conditions, and the nurse practitioner has actioned referrals to GPs. So they've got these families linked into GPs, which they were not before. Got them linked into optometry. We have a fast track optometry system now. We have surgical interventions, ENT. Some of the children had severe tonsillitis. So if they've got severe tonsillitis, they can't go into a really deep sleep because their breathing is not proper. They may even have sleep apnea. And so they need an ENT surgical intervention to help them. If they're not sleeping properly, then they're not going to be able to grow and develop properly, because some of the things that we develop while we're sleeping when we're children. We have a direct referral into audiology for children's hearing, physiotherapy, psychotherapy, and dentistry. Additionally, 44% of the children we saw through the clinic identified as being Aboriginal or Torres Strait Islander. The nurse practitioner provided 75% of the families with home visits, and a lot of this was due to the lack of transport, and some of it was due to the impact of COVID-19. So without the nurse practitioner intervention, these children would have remained disconnected from health and wellbeing and education. The nurse practitioner has provided that vital hub and that vital link to help get these children into all of those services. It's our understanding that this is the first time that a nurse practitioner has been embedded in a homelessness service for the direct provision of care to children, and that we know that children living in housing instability are impacted very differently to how adults are impacted on housing instability or homelessness. We also know that if we can act early in the life of the child, early in the life of the problem, that we have the potential here to actually disrupt a permanent disability, a permanent intellectual disability, or developmental issue later on in this person's life. So we know from some of the research that's been done on developmental delay and disability in childhood in the US, that it costs, in childhood, it costs between $4,000 and $7,000 a year to address the needs of a child with developmental delay. We know that in adolescence that cost rises to $22,000 to $62,000 a year. And we know that additionally in adulthood, there is $14,000 more for someone who has a permanent direct disability through developmental delay that has got left untreated and goes on into adulthood. So if you compare the two adults, a similar social structure and status and income, for the person with the developmental delay that goes into adulthood, it costs them $14,000 more for their own care. And I know that the US is very much individually based care, but it is an important thing to think about. So what do we know about children living in housing instability? We know that 22% of all Australian children are living in housing instability. We know that they are exposed to a cycle of disadvantage that has lifelong impacts. We know that if we intervene early in the life of the child and early in the life of the problem or issue, that we can actually interrupt some of those lifelong effects. We also know that while the housing sector does provide healthcare, that often these services are targeted at rough sleepers. They're not targeted at children, and that families with children 0 to 18 years will tend not to use the services that are there for rough sleepers. That children from homeless families often suffer long-term physical and mental health impacts from the disadvantage. These things include the adverse experiences from trauma. It's traumatic for children to be in housing instability. Domestic violence, which often goes alongside housing instability for children. So their exposure to violence and their exposure to the trauma of being homeless. That there are multiple toxic stressors, and if we think about our brain development and then the impact of cortisol on brain development and our neurobiological development, if that impacts during a sensitive time or a critical time, then it can have long-lasting effects on our cognitive ability and on our mental health if we're exposed to that in childhood. That children are traumatised by homelessness, and that means that there is a higher prevalence of accumulative harm, and there's a higher prevalence of physical things such as dental caries. That children living in housing instability and homelessness have poorer health, poorer education, and poorer social outcomes. So in summary, we know that child development is important and it has lifelong consequences. So we know then that the impact of housing has lifelong impacts on the child's cognitive and social development, and that our exposure to language and socialisation activities can be impacted if they happen during a sensitive period or during a critical period of our development. You are your childhood, so you are as an adult, and that we have over 100 years of research that actually provides the foundation for this. Here is my contact details, and here are the references. I want to thank you for your time and thank you for your attention. Emily, I may actually do this again.